So grossly, to CA larynx, by CA larynx we mean any malignant lesion of the larynx. So that can be in any part of the larynx. It can be. So grossly we divide larynx into three subtypes, subsites. Now I'm not going to show any presentation. I don't like presentations in lecture classes. Though the we divide larynx into three subsites. So what are they? Supraglottis, glottis, and subglottis. So what does supraglottis include? So it is suprahead and infrahead epiglottis. Mention it like that, okay? Suprahead and infrahead epiglottis. The arytenoids, the E folds, and the false chords. So till the level of false chord, it's supraglottis. Below that, it is glottis. Below glottis, 5 millimeter from below the glottis, it is subglottis, right? So, CLRX is an important and a very interesting topic, and it's very one of my very favorite topics. So, the behavior of the malignancy differs according to the subsite. It's very classical for larynx because it's the same organ, but when the lesion is in supraglottis, it behaves completely differently from the lesion in the glottis or subglottis, right? So identification of the lesion is very important. The proper site, staging, that is very important for the treatment of the disease. So what are the causes of CA larynx? How many of you are smokers over here? I know no one will raise hand, but many of you are, right? So the thing is, the most important cause of CA larynx is smoking. Okay. So I was going through Dhingra yesterday to see how much should I go, because CA larynx is a subject of research, and I, being a head neck surgeon, have been working on CA larynx for years. So the thing is, so they have mentioned smoking and alcohol as the most important causes of CA larynx. So obviously, smoking is the first and the second and the third most important cause of CA larynx. Okay, I've rarely seen one patient in my life who is a non-smoker having CA larynx. Rarely. It's somewhat different for oral cancer. In oral cancer, we say about 90% of patients are tobacco users. So there are 10% patients who are non-tobacco users. But in CA larynx, I would say from practical experience, it's around 98-99% of patients are users of tobacco and mostly smoking, because the difference is when they smoke, it goes through the larynx into the trachea. So it's an inhalational process. Okay. But when the person is chewing tobacco, like gutka, khaini, and all those stuff, so they're swallowing it. So the likelihood of hypopharyngeal cancers are more, like piriform sinus cancers. Okay, because the juice touches your hypopharynx, not the laryngeal inlet, because laryngeal inlet gets closed most of the time. So smoking definitely is the most important cause. So alcohol per se, alcohol only, is not a very important cause of CA larynx. There has been multiple research works which has shown that alcohol independently is not a very important cause of CA larynx. But together with smoking, the risk of cancer just does not add up. It increases exponentially. So social drinkers, you're not gonna have CA larynx. But you're smoking along with it, you may have. Okay. So what are the other causes? Obviously genetic causes. Some people have genetic diseases for which they're prone to develop malignancies. Larynx, though, is not a part of many syndromes, but Larynx is second primary disease. We have seen many. Okay, so a patient, how does the patient present? So, what are the symptoms? Stridor, straight away stridor. Yes, yes. So, first you mentioned that larynx, the symptoms of larynx depends on where the lesion is. Like I said, there are three subsites: supraglottis, glottis, and subglottis. So, if the lesion is in epiglottis, say suprahad epiglottis, do you think the patient will present with hoarseness of voice? No, right? But when the lesion is in vocal cords, the patient may present with hoarseness of voice. So, what are the commonest symptoms? For supraglottis, what will be the symptoms? Say there is a tumor in the epiglottis. So, this is your tongue. This is your epiglottis. This is your thyroid cartilage. This is the hyoid bone. Okay. So, a patient presenting with a tumor over here. What do you think the symptoms would be? Dysphagia. Okay. The patient may complain of difficulty in swallowing and the pain in there. Very, very common. Very common. And another characteristic of this tumor is, suprahad epiglottic tumors are exophytic tumors most commonly. They're not infiltrative. So what do we mean by exophytic tumors? So this is the basement membrane. Okay. So exophytic tumors are like this. So the major part is outside. Whereas the infiltrative tumors will grow like this. So the tumors are infiltrating inside the tissue. Okay. So most of these patients we call ulceroproliferative disease, and these are ulcero-infiltrative disease. Okay. So the specific characteristic of suprahad epiglottic tumors are most of them are the proliferative tumors. So sometimes even early disease can cause stridor because since there is a big tumor, it sometimes falls off and closes the inlet. It's called a ball valve action. So there is a big tumor mass on the epiglottis. It can fall posteriorly and cause obstruction of the laryngeal inlet. This is specific for suprahad epiglottic tumors. Okay, while the other parts they usually present commonly with dysphagia and pain in the throat, this kind of symptoms. Now coming to glottis. What do you think the glottis tumors would present with? Tell me. You said right now, just hoarseness of voice, right? The commonest tumors, commonest presentation of glottic tumors is hoarseness of voice, right? Because they are on the vocal cords. So, two things. First is they may cause a phonatory gap, right? So when the vocal cords are closing on themselves, so there is air space in between because they cannot close completely because of the tumor. Okay, and the second is there may be mucosal irregularities. So the tumor may not be right on the surface; it may be submucosal. It may be submucosal, but you know how larynx operates. So when we see the two vocal cords, the surfaces of the vocal cords, if we do a cross-sectional image, so there, when the air comes out from the trachea, what happens is there is a mucosal wave formation over here. Okay, so the glottis the medial ends of the glottic mucosa touches like this. It's like this. It touches like this and opens up. Like this. So this mucosal wave is very critical to produce a proper voice. Okay. So when there is a tumor in there, do you think this mucosa will vibrate like it should? It should not. So many a times we get a lot of patients referred because they miss it. Because they don't see any proper tumor in there or any ulcerations over there. Okay. But the patient is presenting with hoarseness of voice. We get a lot of patients like that. So this is the most common presentation of CA glottis. And what can another reason be? Say this tumor is quite large and is involving the paraglottic space. So once the paraglottic space is involved, paraglottic space means the space lateral to the glottis. Paraglottis. So it is lateral to the glottis. Right? So what is in there in the paraglottis? What lies in the paraglottis? Ventricle. Where is the ventricle? Ventricle is between the false and the true pulse, right? So I am talking of paraglottis, lateral to the glottis. The muscles which helps in movement of the vocal cord. So once there is involvement of the paraglottis, there is palsy of the vocal cord. So the vocal cord is not moving. Okay. So this will cause the hoarseness of voice because this one is not coming in the midline. Even if this comes in the midline, this one comes in the midline, still there is a phonatory gap which is causing a hoarseness of voice. Right? At any step, if you find anything that you don't understand, or you have any queries, please raise your hand. So this is the commonest symptoms of glottis. So what is the commonest symptoms of subglottis? Stridor. So subglottis usually most commonly presents with stridor. So because subglottis is a narrow space. So below the vocal cords, subglottis is a narrow space. It's one of the narrowest parts of the larynx. So here any tumor or any lesion primarily arising in subglottis is extremely rare, to be honest. It's not very common to have a primary subglottic tumor. It's mostly transglottic, that is disease from glottis or supraglottis spreading mucosally to the subglottis. Okay, so these patients, when subglottis is involved, can present commonly with stridor, that is difficulty in breathing. And obviously glottic tumors, apart from hoarseness of voice, if they are big enough, they can cause obstruction of the laryngeal inlet, causing hoarseness, stridor. Stridor is a late presentation. Initially the patients come with hoarseness of voice and gradually they develop breathing difficulties and then this classic stridor. Okay, so once the patient develops the stridor, we have to go in and do a tracheostomy, right? So this is another very important part in any head and neck cancer is the involvement of the neck, right? So we know the deep cervical neck nodes. So this is the sternomastoid, say. So below the sternomastoid we have the jugular nodes, level 2, 3, 4 nodes, right? The supraglottis per se has a very rich vascular supply and lymphatic supply. So supraglottic tumors can commonly primarily present with swelling in the neck, with a level 2 swelling. The patient is saying that I'm having a difficulty in swallowing, and you see that there is a swelling in the neck in the level 2. Okay, so supraglottic tumors can present with a neck swelling or a neck node metastasis. Okay, is anyone aware of the term regional metastasis? What is a regional metastasis? What is the difference between a regional metastasis and a distant metastasis? It's a localized lymph node. So for the primary draining lymph nodes. So if the disease is limited to the primary draining lymph nodes, we call it a regional metastasis. And when it is spreading to a separate organ, we call it a distant metastasis. Right? So here the patients can present with a regional metastasis. Okay? But for glottis, it's not like that. Glottic tumors has very sparse lymphatic supply. So glottis, primary glottic tumors, they don't usually present with neck nodes. They don't have neck nodes. So it's very rewarding. Glottic tumors, treating glottic tumors is very rewarding because the patients usually get well completely. It's a very good success rate of treatment. While for supraglottic tumors, it's not as good. And subglottic tumors are even worse. Okay? So, what are the other symptoms that can patient present with? It's a very advanced disease. Will have distant metastasis, right? So, what is the commonest site of distant metastasis for laryngeal malignancy? কোথায় যায়? Commonly, most of the head and neck cancers, lungs. So, lungs is the commonest site of distant metastasis for almost all head and neck cancers. Okay? So, patient may present with a lung metastasis and will have symptoms of breathing difficulty, maybe hemoptysis, and all those symptoms. Hemoptysis can also come from the supraglottic tumors as well, right? So now a patient has come to you. You have diagnosed. You have come to you with a hoarseness of voice, right? So what will you do? Someone sum it up for me. বল কি করবি তোকে বলছি a patient has come to you with hoarseness of voice. So how will you evaluate the patient? So patient has come to you with a hoarseness of voice for 10 days or 7 days maybe. And another patient has come to you with a hoarseness of voice for 1.5 months. Who do you think is more likely to have a malignancy? Why? See, when a patient is complaining of a hoarseness of voice for maybe 7-10 days, okay. So, have you ever got a hoarseness of voice with a cold, common cough and cold? So, it's very common, right? We can have a vocal cord edema at any point of time. We can have common cough and cold, a vocal cord edema. So persistent hoarseness of voice beyond 3 weeks is something that will bother you. Okay, an acute onset hoarseness of voice for a few days usually is not very worrying. Okay, so this patient has come to you with a hoarseness of voice for 1.5 months. Okay, elderly male patient, maybe a 55-year-old male. What histories will you take?
Whether he smokes or drinks.
Smoking, so personal history and or social history. So we will take history of smoking and alcohol consumptions. Okay, what else? What are the other important things? Family history, very good. Why? Genetic, to have a genetic background. Okay. So most of the CA larynxes are sporadic diseases actually. Okay, it's not very commonly familial unless it's a part of a gross familial, like a gross mutating, like a normal type of P53, not a wild type, and all this. Very rarely, very rarely. CA larynx doesn't usually have a syndromic predisposition. I mean, not a syndromic occurrence. Occupational history, very, 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 very good. So occupational history, why? Huh. So what are the things that we have to note in occupational history? One is vocal abuse. So first is vocal abuse. So a patient may have a vocal nodule for 3 weeks, 4 weeks, right? So that's okay. We see a lot of patients with vocal nodules for 4-5 weeks. Okay, until they feel like it's time to go to a doctor and see one. Okay. So the patient has come to you with 1.5 months history, so it can be a vocal nodule as well. So we'll ask his or her profession. So teachers, singers, they may have hawkers, yeah. So those who are shouting or forcing their voice out, okay, has a tendency to develop vocal cord nodules. Another, someone told me, asbestos industry, very very good. So some fumes, people who are exposed to cement, asbestos, this kind of chemical industries where they produce a lot of fumes, can be predisposed to chronic irritation of the larynx and subsequent development of malignant disorders. Okay, very good. Next, now you sit down. Well, what next? Oh, what else? History is over. We have taken the chief complaint part, the occupational history you have said. Next, what comes? Personal history you have taken, family history you have taken, then past history. It's important. Why? You need to know whether you are treating a recurrent disease or a primary disease. So in malignancy, any case of malignancy, never forget past history. Okay, it is important because a person, so a person they're having a head and neck cancer, okay, has the likelihood of developing a second primary malignancy much more than a normal person who has not developed a cancer. Okay, so it's very very important. And another thing is there may be a history of radiation exposure. Okay, so radiation exposure can also cause head and neck cancers. Most commonly stridor, larynx is relatively less common, but radiation exposure history you have to take. So these two are very important things. Okay, so now you have taken the history. Who will be next? Ayush, get up. Get up, get up. What next? So we have taken the history. We have, so what points do we have? It's an elderly, he's an elderly male patient, maybe 55 years old, presenting with hoarseness of voice for 3 weeks or 4 weeks with moderate dysphagia, no breathing difficulty till now. Okay, smoker, occasional alcohol drinker, and but heavy smoker though. So family history is negative, no prior history of any treatment or radiation exposure. So what is my next step? What would I do in my OPD? That will not cure his cancer. That's very good. Obviously, we'll ask. Yeah. So you know the best way to quit smoking is to have a cancer. So this was told by one of the professors from Tata Hospital, Bombay. So he told that the best way to quit smoking is cancer. So that is something obviously will guide your patients with. You'll always tell your patients. But what will you do next? Come to the examination part. Examination. Okay, so what do you do in the OPD? What type of laryngoscopy do we do in the OPD? Indirect laryngoscopy, because we are seeing through a mirror. Do not forget this. Many of you make this mistake, and we also honestly have done this mistake in the past. So indirect means since we are not directly visualizing, we are seeing through a mirror. It's a reflected image. So it's an indirect image. Okay. So indirect laryngoscopy we'll do in the OPD. Okay. So what do you see in the indirect laryngoscopy? What all structures do you see? Base of tongue first, then gradually, like I told you in the class before, right? So gradually grow from above, below. First comes base of the tongue, then comes between the base of the tongue and epiglottis. What do you have? Vallicular. Important, because primary vallicular disease we have seen a lot. Okay, it's important to visualize the vallicular properly. So base of tongue, vallicular, then epiglottis, then straight to subglottis. Where is the glottis? Airy epiglottic folds, arytenoids, rheumatoglottis. There is a glottic opening. Okay, vestibule. Vestibule we cannot properly see with a indirect laryngoscopy though, but then again you mentioned it, vestibule, arytenoids, and on either sides pyriform sinuses. Okay, very important. And the postcricoid. So postcricoid we normally cannot visualize with a indirect laryngoscopy, but postcricoid is something that we need to see. Okay, so once you have seen, so there is a growth in the left vocal cord. Okay, so apart from knowing that there is a growth, what else would you see? So you've already seen that there is a growth. Okay, so what are the other points that you need to see on the while doing the indirect laryngoscopy? What? Extent of the lesion, obviously, yeah. Then indirect laryngoscopy. You're doing an indirect laryngoscopy. I'm asking you what are the points that you need to see on indirect laryngoscopy? Mobility of the vocal cords. This is a must, must, must. Only on visualization of the larynx you can assess the mobility. Once the patient goes in for a general anesthesia, you will not be able to assess it while taking a biopsy. So you have to do it in your office. So mobility of the vocal cords, you cannot assess it on CT scan. You cannot assess it while under GA, while the patient is under GA for a biopsy. So only time to assess it is in your office. Okay, in your chamber. So mobility of the vocal cords is very, very important. Never forget this. Okay. Then what comes next? Extent of the disease, he said. Okay, so a glottic tumor, how does it normally extend? Where would it go? Put a ball? Tell me now. I don't shout, I don't scold. I try to make you understand every single point. It's very important to understand. So, see, why I am telling you this, I'll show you. Say, these are the vocal cords. Okay, and we have the arytenoids over here. The base of tongue is the epiglottis. This is the epiglottis, the E4. Okay, this is how we see in the indirect laryngoscopy, right? So, what are the points? First is we have seen a growth over here. Okay, so that's the growth is there. Someone told me mobility, right? Then we have to see whether this disease is involving only one vocal cord, whether it's involving the anterior commissure or not, whether it is going to the other vocal cord also or not. Why? This will change the staging of the disease. Okay, that's why we need to see it. And also my treatment, obviously with stage, change in stage, or treatment will change, right? This thing, mobility, and any disease in the postcricoid region or the pyriform sinus, because there can be multiple primaries, like I told you. In head neck cancers, there can be multiple primaries. So what are they called? They're called synchronous primaries. Okay, so there can be synchronous primary diseases in the larynx as well. So it's important. Now, after doing an indirect laryngoscopy, what else would you do? Examination part, I'm saying. Laryngeal crepitus. Okay, it's important. We normally don't do it. It's very rarely done unless it's a very extensive disease and we are suspecting. So when will the laryngeal crepitus go? Is it normal to have a laryngeal crepitus? It is normal to have a laryngeal crepitus. Not having a laryngeal crepitus is abnormal. Why? Because the larynx sits on the vertebra. So when we move the larynx, you can feel move it, you will feel a gritty feeling. That is called laryngeal crepitus. Congratulations, you don't have C larynx. Huh? So once you have that feeling, that's normal. So once there's involvement, no, don't move your sternomastoid, move your larynx. That's the sternomastoid. Larynx is in the midline. Yeah. Okay, so this. So laryngeal crepitus is normal. Once you lose it, that means there is involvement of the prevertebral muscles or the prevertebral fascia. So that is a very bad sign. That means the disease is not even operable. Okay. So after that, we will examine the neck for the neck nodes. Any head and neck cancer, do not forget examination of the neck. Okay, because that is a part of the staging of the disease. Okay. So what in the neck? The level of the nodes involved. So most commonly involved node is level 2A. Level 2 I would say, not 2A, level 2. Okay. 1A, 1B is almost never involved in laryngeal malignancies because those are not the primary draining nodes. So level 2, 3, 4, 5 are commonly involved, and prelaryngeal nodes or Delphian nodes are involved sometimes. Okay. So after that, we'll order the investigations. What investigations would I do? CT what? CECT, very good. CECT of neck. Then I don't like to be very bookish. I like to go out a little bit so that you can feel the subject. It's important. See, if you have a small growth in the vocal cord, so the CT cuts may miss it, right? So what is the normal CT cut? We take a 5 millimeter cut. Like on some places it's a 10 millimeter cut also, like 1 centimeter cut also. So grossly, for most of the places for 64 size CT scan, we have a 5 millimeter cut. But for larynx, you cannot afford to have 5 millimeter cuts. That's too wide because the vocal cord thickness is only 5 millimeter, so even lesser than that. Okay, so we would write a contrast CT scan of the neck with 1 millimeter slice for larynx or thin cuts for larynx. When we are taking a thin cut for larynx, we will be able to appreciate the disease in the vocal cord. Okay, and always remember, we always practice, all oncologists practice this: CT scan followed by biopsy, not the other way around. We don't do biopsy first, we do a CT scan first. Why? Because once the biopsy is done, there can be local edema and it can be misguiding when you do a CT scan. Okay, so we'll order the investigations: CT scan of neck, then we were talking of distant metastasis, right? We have to rule out X-ray of chest. Nowadays we do CT scan of the chest only. Okay, that's fine. Then X-ray, if you do a CT scan, X-ray is not required anymore. Other endoscopy, so fiber optic laryngoscopy. So fiber optic laryngoscopy is for better visualization. So ideal is something that's almost obsolete now, but for examination purpose we have to learn it. But once you're practicing, very rarely you'll be doing indirect laryngoscopy. So most of the times we'll do a fiber optic laryngoscopy. We have endoscopes, we have Hopkins telescopes, okay, which are angle telescopes, and we can visualize the larynx. If fiber optics are even better, they're flexible, so you can go in more close to the larynx, get a better visualization. Okay, then fiber optic laryngoscopy, then we'll go ahead and do a CT scan. Then next, blood investigations. I'm not going into details, everyone knows it. For every disease it's almost the same. Regular blood investigations, chest x-ray, ECG, all those stuff. Then we are going to plan a biopsy, right? So a laryngeal biopsy ideally needs to be done under general anesthesia. Why? So the procedure is, so there can be movement. Okay, that's important. So larynx, when you go close to larynx, you take a biopsy, there can be movement, and you may take the biopsy from a wrong place or may injure structures. Okay, that we don't want, obviously. Very good. And another very important thing is, when we do a direct laryngoscopy, we do not only take a biopsy, we assess the disease. Okay, so we assess the disease under direct vision and we palpate the disease. How do? We don't palpate it with fingers, we cannot go into the larynx. We palpate it with a suction tip because there is something in malignancy called induration. What is induration? Induration is something that is submucosal disease. Okay, so with the suction tip under direct visualization with laryngoscope under GA, the patient is under GA, we assess the extent of the disease, the involvement of the disease. Like, for example, the post-cricoid space, post-cricoid region. You can never assess a post-cricoid region on fiber optic laryngoscope because it's hidden behind the arytenoids. Even if you go close, you won't be able to assess it. To lift up the larynx with our laryngoscope and see the post-cricoid region. Okay, so pyriform sinus, you need to assess. Okay, so primary evaluation of the disease extent is very important, and we palpate the paraglottis with the suction tip. If it's hard and firm, we expect that there may be disease in there. That changes the stage of the disease. Once the paraglottic involvement is there, it's T3. It is limited to the vocal cord T1. So the treatment completely changes. Okay, so we have to assess the extent of the disease. So now, and then we take a biopsy and we send it. So it has come as a moderately differentiated squamous carcinoma. So what is the plan of treatment now? So here I'll tell you something. It's I kept the last 15-20 minutes for this treatment only because it's very interesting. There's a lot of changes in the treatment of larynx over the last 3-4 decades. So initially, in the earlier days, when my people started to diagnose laryngeal cancer, all malignancies of the larynx were dealt with surgeries, major surgeries like total laryngectomy, including total thyroidectomy, because we will find out that okay, there is a very aggressive disease, so we need to treat aggressively. Okay, but the treatment paradigm has changed a lot. There has been a cross change in the treatment of CA larynx. So now we divide laryngeal cancers into early cancers and advanced diseases. So early cancers are T1 and T2. Advanced are T3, T4. Right? Achha, so who knows about the staging of laryngeal cancer? Can anyone tell me about the gross T staging of laryngeal cancer? পড়ে এসছিস তো TNM classification উঠে দাঁড়িয়ে I will be very happy if you can tell this দাঁড়িয়ে বল as much as you can take.
T1 is limited to one vocal cord, means limited to one side only in T1, and in T2 either one or two. T1 is one vocal cord and T1B is both the vocal cords.
কে বলতে পারবে? Who can tell me? Someone from the back? পড়েছিস না পড়িসনি? বলছে না পড়িনি। So T1 is one subsite. So it's glottis only involvement, it can be T1, T1A or 1B. 1A is one side involvement, 1B is both sides involvement. Okay, T2 more than one subsite. Okay, so there may be involvement of the other subsites like a supraglottic tumors coming to glottis or glottic tumor coming to supraglottis. T3 clinically we assess when there is paraglottic involvement, or there is once there is paraglottic involvement, there is fixity of the vocal cords, right? There will be loss of movement of the fixed hemilarynx or fixed movement of the vocal cords. And another thing is minor thyroid cartilage erosion. This is important because thyroid cartilage erosion changes our treatment. Okay. So thyroid cartilage erosion, assessing thyroid cartilage. So if the vocal cords are like this, so thyroid cartilage is like this, right? Okay. So disease in the vocal cord limited here is different than disease going outside the thyroid cartilage. Why? Because that will change the treatment plan a lot. So there was one trial, we call it a VA trial. It's a 1991 Veteran Affairs trial. So like I said previously, we used to dwell on doing surgery for all malignant lesions of the larynx. Okay. So all malignant lesions were dealt with surgery. We used to do a total laryngectomy. So no space for conservative surgeries. Okay, no space for surgery. But gradually people started doing conservative surgeries. So they thought that why do I need to remove the entire larynx for a small disease? Maybe early vocal cord disease. Why do I need to remove the entire larynx? So there was a trial, like I said, it was based on comparing other forms of treatment along with surgery. So they said that using chemotherapy followed by radiotherapy and surgery followed by radiotherapy gave the same result. So what is the advantage? You can preserve the larynx. So it's wrongly written in your book. It's in Thingra. It's written that NSAT, adjuvant chemotherapy followed by RT was better than surgery followed by RT. It's not like that. It's the same. Okay. So the results were same. There were around 260 patients in each arm, 520, 530 patients overall. And the results after 5 years were almost 66% of laryngeal preservation. So in 66% of patients, we could preserve the larynx. So giving chemotherapy and radiotherapy, you are keeping the larynx there, right? Okay. While surgery means you are removing the larynx. So the patient will never be able to phonate, will have a permanent stoma in the neck, will never be able to swim. It's very difficult for him to hike mountains or lift a weight because he won't have that intrathoracic pressure developing. Okay, he'll be leaking air from the stoma. So he will not be able to do all the stuff. So sacrificing larynx, because larynx is a very important functional organ. Okay. So what is the most important function of larynx? Protection of the air. Whenever say phonation. Phonation is the second important function. First is protection of the airway. So once the larynx is gone, your airway is exposed. So the stoma is directly outside. Okay. So like I said, for advanced, so first we are discussing advanced diseases. I'll come to the early diseases later on. For advanced diseases, initially, so all patients are used to undergo surgery. Gradually, after multiple trials and multiple studies over the world, we have found that chemotherapy followed by radiotherapy gives almost same result as surgery followed by radiotherapy. What advantages we are getting? Laryngeal preservation. Okay, so that the patient, voice will be hoarser, obviously voice will be bad, but still the protection of airway function will be better. Okay, and after that the patient will undergo radiotherapy. So a lot of side effects of radiotherapy are in there, both the arms. This was also NSAT followed by RT. That was surgery followed by radiation. So same. So side effects of radiation we are getting in both the arms. So it's not a problem. So nowadays we have seen, it has been shown that once there is erosion of the thyroid cartilage, radiation does not work. Once there is a through and through erosion of the thyroid cartilage, the radiation does not work. So we operate advanced CA larynx only in patients who have a through and through thyroid cartilage erosion. Here, if you send the patient for radiation therapy, will not work. Okay, so it's a chemo radiation that we give nowadays. So from, like I said, NSCT-RT, it has now come to a stage where we are giving chemo radiation for advanced CLRX. So like I said, see, T1, T2 disease are early diseases. So our early diseases, there is a single modality of treatment. We need only one treatment. For advanced diseases, it's a multiple modality treatment. So either at least two, either surgery followed by radiation therapy or chemoradiation therapy or neoadjuvant chemotherapy followed by surgery followed by chemoradiation. So based on the merit of the disease, we decide the treatment plan. We don't have to go in so much details. What I want you to know is, for advanced diseases, we need at least two modalities of treatment. For early diseases, one modality is sufficient. Okay. So here, so the indication of surgery in CL larynx is কি হচ্ছে বল? Just said na? Thyroid cartilage erosion is a very, very important indication of surgery where radiation therapy will not work. Laryngeal preservation will not work. Okay. And another very important indication of surgery is dysfunctional larynx. When the disease is so bad that the larynx is already not functional. So there is no point in keeping the larynx. There is gross dysfunction of the larynx. So there is aspiration, recurrent aspiration, and the airway is getting more harmed than being protected. So you go in and do a surgery and remove the larynx. Okay, and separate the airway and the food pipe. Right? Now coming to this single modality treatment for early diseases. So there has been a debate over years that what do we do? Should we go for radiation therapy or should we go for surgery? So it's very debatable till now. For early diseases, depends on the location of the tumor. So nowadays we have something called a transoral surgeries. So we can use lasers and remove the primary lesions through the oral cavity through a laryngoscope using a CO2 laser, or sometimes we can directly do it. Okay, so microlaryngeal surgery with CO2 laser for early vocal cord lesions is the treatment of choice for early T1 diseases right now. But previously, all these patients would go for radiotherapy. Okay, but it has been shown that radiotherapy doesn't work. Radiotherapy doesn't work very well when there is involvement of the anterior commissure. When the anterior commissure is involved, so there is a lot of debate about the success of both laser surgery and radiotherapy. So sometimes we have to do an extensive surgery for anterior commissure involvement, or because it's very close to the thyroid cartilage, right? So we send the patient for. Just remember this thing. So early vocal cord lesions or early laryngeal lesions, we prefer to go for limited surgeries nowadays, like transoral laser surgery or transoral robotic surgeries. Okay, so now we have the robots. For surgeries, for diseases which are not amenable for local resections, we prefer to go for radiation therapy directly. no neoadjuvant, directly radiation therapy. Okay, this much done. Next is when the disease is advanced. First choice would be laryngeal preservation. We will see whether we can preserve the larynx or not, because obviously it will give a very good, better, much better functional outcome for the patient. If there is gross involvement of the thyroid cartilage, or in case of dysfunctional larynx where we cannot preserve the larynx, we'll go ahead with a laryngectomy. Okay, partial laryngectomies, like I said, there may be centrolateral, posterior, so many types of partial laryngectomies are there, but practically they are not, very rarely done, because the post-operative period in these patients is very morbid, and we lose a lot of patients in the post-operative period. We've done the surgery very well, but the patient could not recover from the surgery. That's not a point. Okay, because ultimately we are treating the patient, not the disease, right? So post-operative period should be good enough for the patient. So limited laryngeal surgeries, partial laryngectomies are very rarely practiced nowadays. Either go for a total laryngectomy or you go for a transoral resection. Okay, and I missed one thing before all this planning. One thing you must be sure that you have done a CT thorax, like I said, there should not be any distant metastasis. If there is a distant metastasis, the intent of treatment changes. So all this becomes a palliative treatment. So all these are curative intent treatment that we are talking about. We have to cure the patient. Our goal is to cure the patient. But once there is distant metastasis, there is no role of any curative intent treatment. In head neck cancers, it's not for other cancers, it's different. For head neck cancers, there is no role of any curative intent treatment. Yeah, one small topic. This is not very important in the undergrad syllabus, I guess. So, rehabilitation, voice rehabilitation or rehabilitation after total laryngectomies. So, your larynx is gone. So, what do you have? You have a neoesophagus, a neopharynx, right? So, have anyone seen a total laryngectomy surgery, video or anything? Never, right? So, what we do is we open up like this. It's called a Gluck-Sorensen incision. It comes like this. It's like a flap. We raise it. We expose the larynx, okay, along with the strap muscles on it. We take a cut below in the trachea, and the upper cut is in the vallecula. Okay, so we are entering above the epiglottis. Okay, so laterally, after that, we catch hold of the epiglottis, we pull it out and visualize the disease and take the cuts around it. So, what happens is, say, so say this part comes out, right? The cartilage part comes out. Okay, so now up to this level, so we have entered through here, like I said, we entered the vallecula. Understood? So we are cutting from here. We are cutting like this, taking this thyroid cartilage, cricoid cartilage, and the first or second tracheal ring out. So this is a specimen that I am removing. Okay, and this rest of the trachea, this hole. Okay. So this suture to the skin to form the stoma, so that the patient can breathe. So that would be the airway.